Okay, I'll continue to admit folks as they knock on the virtual door. I want to welcome you all to the System of Care Advisory Council bill reading event. We will be going through what is now called Legislative Concept 4714, which you should be able to see up on your screen. It's the document on the left over here that says draft at the top. We're going to go through it kind of by content section. So we'll start with regulating restraint and seclusion and placement settings, talk about what's in the various sections of the bill that address that, rather than reading it from top to bottom, because it's content kind of spread throughout the bill, and it's pretty confusing if you go from restraint and seclusion in schools to placements to schools again. So we thought we would do it by topic area. Hopefully that will help people kind of track what's going on in this bill. It is a long bill. It is a complicated bill. There are 115 pages. Michelle can speak a little bit to why that is the case as well. Today, the goal is to read the bill out loud, talk about what's in it, understand what it is and what it is doing. We are not able to take suggestions during this conversation for amendments, changes, edits. That there will be a process for that. You're welcome to submit those kinds of suggestions via email. You can email me. I'll put my email in the chat. Or you can email, well, let's just say you can email me. I'm happy to. My email address, for those of you who might be reading it in a transcript, is anna.k.williams@oha.oregon.gov. And it is also now in the chat. We are recording this session, so if you do not wish for your image to appear on YouTube, please make sure your camera is turned off. We will be posting these recordings to the System of Care Advisory Council YouTube page. It'll probably take us a couple days because we're going to use the transcript and put timestamps on the video so that if you're interested in schools, for instance, there'll be a document that says the conversation about schools starts at this time. So please let me know if you have other questions in terms of what we're doing here today or how to go about it. Questions for clarification and understanding, if you want to put them in the chat, I will do my best to read them out. Joylene will also be here to read them out if that's your preference. You can direct chat her and she'll read your question or comment out if that is a more comfortable way for you to engage in this conversation. Joylene, would you like to introduce yourself quickly?
Hi, everybody. My name is Joylene Carter, she, her pronouns. I work at SOCAC as the Youth and Family Engagement Strategist. So I am here if you need to direct message me. I can read whatever question you have out loud. If you need some anonymity, I got your back. Thank you.
Thanks for being here, Joylene. We do expect 2 hearings on this bill in the House Human Services Committee sometime in mid-March. Those hearing days are not confirmed yet, and so I cannot provide them to you quite yet. But as soon as those hearings are scheduled, we'll be messaging that out on the System of Care Advisory Council webpage. And of course, it will be available on OLIS, the Legislative Information System, which is where you go to find bills and track hearings and things. I think that is it for intros. Our chair, Adam Rudakowski, and co-chair Annette Magicotami are here. Co-chairs, are there anything you would want to say in terms of setting the stage for this day 1 of the bill reading? We'll also be doing this for 2 more hours on Thursday from 4 to 6 as well. So whatever we don't get through today, we'll hopefully be able to get through on Thursday.
I don't think I have anything to add, Annette.
All right. Well, I will turn it over to Michelle. Oh, I'm sorry, Annette.
No, nothing to add. Thank you.
You're welcome. Thank you.
If possible, I'd like a little bit of feedback from the group. If I don't know, is there a reaction ability here? Like, can people raise their hands or something on if they've been able to read the policy brief yet? or not? I'm trying to think through if we should read at least the part of the challenge that we're trying to solve, and then I'd be happy to share all the proposed changes in the different sections, or if that would not be worth our time.
Adam?
Well, I mean, I'm raising my hand to show that we can raise our hands because I have read it. So yes, you can add me to the I've read it list.
Okay. And Rachel Gittner in the chat says, I would love to hear the policy brief. And Karen, is that how you say your name? Also raised her hand, I think, to say she did have a chance to read the brief.
Karen, and I read it.
Karen, thank you.
Yes, so I guess I'll read I think it might help with some context before we dive into like the meat of what's changing in the legislation, just to give a preview of what the challenge is that we're trying to address. So I'm going to read from the policy brief. I hope that's not too boring. I'm also not a great reader, so I'm going to do my best here and appreciate y'all's support. So the first section we're going to be looking at is around regulating restraint and seclusion, specifically in placement settings. The challenge that we're trying to address is Oregon's definitions of wrongful restraint and wrongful seclusion and child abuse laws are inconsistent, causing confusion among mandatory reporters, families, and youth, as actions may be considered abuse in some settings, but not in others. In addition, current law places liability fully on frontline workers. These issues can undermine care quality as workers may prioritize risk mitigation over active engagement with youth. Proposed changes create more clear definitions of wrongful restraint and wrongful seclusion and aim to shift accountability where appropriate, such as holding leaders and management accountable for systemic failures like inadequate training or staffing resources. Additionally, the restriction to 3 provided crisis intervention models has created a barrier for new providers who are already using other nationally recognized models. Expanding treatment options and removing barriers for new providers to serve children in Oregon is critical to improving access to timely care for youth with complex needs. So we're going to dive into the actual legislative concept that we have on the screen. Starting with sections 1, if you can see in the policy brief, what I try to do is highlight which sections cross over with this policy. So you can kind of follow along, but that's how I'm going to be jumping through these different sections as Anna kind of described. So section 1 of the bill really is a completely new statute to centralize the location for universal definitions around restraint and seclusion regulations. As you'll see, this new statute defines chemical restraint in a consistent way with Medicaid, defines child, which is already consistent with existing statutes, defines corporal punishment as already currently defined in schools and is consistent with the child in care abuse definition of willful infliction of pain, but we now have one centralized definition. Defines developmental disabilities, residential facilities, again, consistent with existing child abuse statutes. Defines foster parent to now include OYA foster homes. I do want to note here, IDD foster homes, or those that are serving children with intellectual and developmental disabilities, are actually considered in statute to be a developmental disabilities residential facility. I know it's a bit confusing, but I want to make sure folks know if you don't see that under foster parent, that's not missing. It is simply captured in a different way in statute. We then have a definition of involuntary seclusion, again, that is consistent with existing statute. We define public education program, consistent with existing statute, defines responsible individual. And this is our way of really kind of creating the world of who is investigated for allegations of restraint and involuntary seclusion. This is not every individual in Oregon. These are specific folks who are in specific roles caring for children. I'd be happy to go through those in more detail if we need to kind of at the end of this summary, but I just want to get through this section first. We define restraint, which is consistent with existing statute. And then in 2 is actually what the new definition of wrongful restraint as an allegation of child abuse is. And it's really broken up into some key sections. This one is for wrongful seclusion for 2, and it really is when a responsible individual places a child in involuntary seclusion for discipline, punishment, retaliation, or convenience of one or more responsible individuals. And then it has the same clarifying language that we have currently, which that it is just wrongful seclusion is distinct and different from like age appropriate discipline like timeouts that may be used in a child's foster home and as a regular parenting practice. Section 3 here is what defines an allegation of child abuse for wrongful restraint. And I think it's important to walk through these key elements of what in the future definition of child abuse involving restraint would include. And that's when an individual either places or directs, whoop, you shifted on me just a second. Individual places or directs the placement of a child in a restraint, and the restraint is used for discipline, punishment, retaliation, or convenience. The responsible individual administers or directs the administration of a chemical restraint to a child, or the responsible individual restrains or directs the restraint of freedom of movement to a child through excessive or reckless use of force that results in or is likely to result in serious physical harm to a child. And then lastly, on little b of that section, whoop, Anna, we went away.
Sorry, somebody asked if I could just make that the only thing in the window,
Okay.
and I'm trying to do it, but I'm gonna have to stop sharing for a second because the like share button is right on top of how I would expand.
No worries. I have a hard copy here I can reference.
And then I'll make it bigger, and then I'll share it again.
And we took a lot of feedback back on how do we describe kind of what is not wrongful restraint, and really kind of wrestled with some of that language. And I think we came up with something that aligns with kind of Medicaid's expectations as well as kind of what the intent is here. And that's in little b. The temporary restriction of freedom of movement of a child is not wrongful if it is applied consistent with the intent to support the safety, healthy development, and well-being of a child, and is aligned with the child's developmental state and individualized needs. So again, this is kind of an example of when we're talking about very little children in foster care, temporarily restricting their freedom of movement, like to move them away from going and touching a hot stove or some kind of object. We would not say that that's technically a restraint, nor would that be a wrongful restraint, that could be a normal parenting type behavior because it's a temporary restriction that's not intended to immobilize somebody. And then lastly, 4 is making it very clear any responsible individual may not inflict corporal punishment on a child. That is the end of section 1. I just wanted to pause there and see if anybody had any questions about that key section before we dive into kind of how that section is implemented in the other sections of the bill. Okay. If we could, sorry, go ahead.
I have a question. I can't figure out how to raise my hand. I'm sorry. If no one else has a question, I would just like to ask one. So if we go back, it says that I'm not going to try to paraphrase it because I'm going to get it wrong, but about sort of not restricting the child, or let's see, I'm trying to. If the involuntary seclusion is an age-appropriate form of discipline, including but not limited to timeout or reasonable action, so I'll just give you an example. So at the organization I work at, we've had several students pull the fire alarm. And the issue is that we can't predict the future in terms of what will happen once that child pulls the fire alarm. We know from past experience that when a child pulls a fire alarm, um, lots of children become really dysregulated and uh, it becomes really dangerous. It becomes a dangerous situation for both staff and students. We've had like 13 fire alarm pulls over the year. Uh, so, but our staff is really confused as to whether they can reasonably like restrain a child from pulling the fire alarm. So the question is, I mean, this seems to give staff still a lot of leeway in determining what is reasonable, but if we could get the answer to that question in itself, that would be a big help. But
Rachel, I think what I'm hearing from you is, are you thinking about in school settings in particular?
I am thinking about in school
Okay.
settings, yeah.
There's going to be a whole section on schools after we
Oh,
get
I'm
to
sorry.
placement settings. No, I just want to just direct you that we will get to that in just a little bit. And I think it'll make clear this is really what is going to be investigated for child abuse. And then we have other sections of statute that talk about what are the criteria for school and in placement settings that is the criteria that has to be met for a restraint to be permissible or not. And I think that
They're
will
like sort of two different things, Rachel. So, and that's where what this bill is trying to do is separate out right now. It's very confusing what needs to be investigated as child abuse versus what other types of investigations are appropriate to say, okay, you did something wrong, but it wasn't child abuse. You know, we're trying to create opportunity for a clear line between abuse is abuse is abuse, no matter where you are, no matter what setting you're in, versus what are some human resources challenges that we need to address via training or supervision or other strategies? And those things are a little bit different in the school setting for a variety of reasons. So right now we're just in this treatment setting space, and we'll jump to schools when we get to that section of the policy brief. It's a great question, but it just we'll pick it back up when we get there.
Okay, so you're saying this section is specific towards inpatient facilities or non-school facilities? Is that what you're saying?
Yeah, this is specific to child caring agencies, which are a whole host of different programs for children, like residential,
Yeah.
boarding schools, all of that. And then we have a school section, and then it also, like, this would also include, sorry, school section is separate. This would also include the IDD facility settings, as well as foster care settings.
Thank you.
Yeah. Okay, so jumping
Michelle,
to
Emily Cooper also has a question. I don't know
sorry.
if you want to
Yeah.
pick that
No,
one
I
up
can't
now
see
or
any of that, so if you could just let me know, that'd be great.
happy to.
Michelle, so this is Emily Cooper from Disability Rights Oregon. You said that there was some sort of vetting that these definitions meet with Medicaid requirements. Can you tell me a little bit more about that?
Yeah, we had a meeting with OHA and some of their Medicaid folks in making sure that these definitions would align with Medicaid expectations, and did a little wordsmithing with them.
Got it. But there's been no guidance requested from CMS, Centers for Medicare and Medicaid Services?
Not that I'm aware of.
Okay, thanks.
All right, jumping to section 12, are you ready for that, Anna? So the section 12, to kind of categorize this section of statute is really around it's a definition section for what I call child and care settings, but it's these type of placement settings, specifically regarding restraint and seclusion. So you'll see section 12 removes definitions of chemical restraint, involuntary seclusion, and restraint, and references the universal definitions that we just looked at in section 1. So although you see the italics here, which means they're being deleted, they're really just being pointed back to the universal statutes. So we ensure that there's always consistent alignment with these defined terms in all of these settings. Section 12 also adds, if you could scroll down, Anna. It also adds, it'll have a mechanical restraint there. Scroll down. It has what mechanical restraint does not include. And this language currently exists in ORS 339.288, which applies to school settings. So again, we're just trying to have absolutely consistent terms and definitions, regardless if children are in school or if they are in one of these placement settings. So this just clarifies a mechanical restraint is not a protective or stabilizing device ordered by a licensed physician or a vehicle safety restraint, seatbelt, when used as intended during the transport of a child in care in a moving vehicle.
Are you going somewhere? No.
Ooh, okay. Going to section 13. This is the child in care restraint, kind of what is prohibited for child in care restraints and involuntary seclusion. You'll see in this section that we've added OA foster homes to be included and also added language to little e and little g. And this was really pulled from section 14 to improve readability. Right now, these are current exceptions, but they aren't all in the same place. So when people read this statute, they wouldn't know unless they go to another statute that there's an exception. For example, to use the intentional or non-incidental use of a solid object because there is imminent life-threatening injury or to gain control of a weapon. Same as with around pressure to the mouth. I think that's G, if you could scroll down more, Anna. And that is around extracting a bite and pressure being put on a mouth because that is a technique trained in our crisis interventions. I think people call it feeding the bite, but it's pushing pressure into the mouth to be able to get the bite to be released. And that's all that's in section 13. Going to section 14, this is the child in care permissible use of restraint and involuntary seclusion statute. So this has conforming amendments, continually using the new term serious physical harm, and we also add including animals after learning of some situations where folks did not know if they could physically intervene when a child was harming an animal. And so really what this section does, it reorganizes existing criteria. When you see A, B, and C there, that's not new. It just is reorganized better for readability. It removes confusing language around what is a restraint and physical intervention, and instead makes clarification in section 3 to differentiate what is a permissible action to physically intervene without immobilization, and then specifically what is a restraint. I'll give a pause there for you all to see that.
Michelle, can I pause you? We have Emily
Yep.
Cooper for the question.
Okay.
So if you look at the first section, it looks like the main change is removing the word reasonable. And why that?
That was actually some research that we had done with other states and removing some of the subjectivity around including reasonable, that really there needed to be risk of imminent serious physical harm as a higher standard than having reasonable there.
And so like
Michelle, you cut out for a quick minute. What Michelle said was that removing reasonable is a higher standard than what we have currently in Oregon law.
So, for example, if someone thinks there's a risk of imminent serious physical harm, but it's not reasonable, it just as long as they thought it was a risk, then there's no determination whether or not that assessment of risk is reasonable or not. And because to me, that goes the other way.
I think we have a different interpretation there.
Yeah, we can note that.
I think we got through section 14. I just wanted folks to be able to see section 3. Um, Again, this is so notwithstanding sections 1 or 2, a child caring agency, proctor foster home, certified foster home, adjudicated foster home, or developmental disabilities residential facility may physically intervene without immobilizing a child in care if the intervention is necessary to break up a physical fight or to effectively protect a person from assault or other physical harm, other serious physical harm or sexual contact. Right now, there's some pretty confusing language in there about like escorting a child down a hall if they're not resisting. And I think it caused a lot of confusion because that was labeled a restraint. And then physical intervention language was there. And so we just tried to get to the heart of what we believe the intention of the statute is, which is clarifying in urgent situations, if you need to physically intervene for the safety of a child without immobilizing a child, that is not considered a restraint. And then going to section 15, this is a statute regarding the requirements of programs around procedures and reporting related to restraint and seclusion. Really, the policy change here is to provide an opportunity for specific legal parties or legal guardians of a child to be able to review video of a restraint that happens in one of these placement settings rather than actually getting a copy of that video, which created a lot of worries about liability and kind of I think NAMI also had concerns around kind of confidentiality around that and kind of what children's rights were to that, which then leads into adding the clarification on youth consent for the release of that video if they're over the age of 18. And also section 5, if you could go down, aligns the reporting requirement language with schools. So if in connection with the use of restraint or involuntary seclusion, program personnel die or suffer serious physical injury as defined in ORS 161, the program needs to provide specific written notification on that incident. Again, just trying to get folks to be reporting the same thing, the same language kind of threshold, and regardless of what setting the incident's happening in. Section 16 is around child and care restraint and seclusion training requirements. The change really here is the restriction for only 2 to 3 crisis intervention programs to at least 4. It also requires an advisory committee with people with lived experience to provide recommendations to the department on selecting these crisis intervention training programs. And also clarifies, if you go down a bit, language between what is meant by a physical intervention versus a restraint. So if you see right there, just try and make it clear when we're talking about the use of restraint versus kind of those physical interventions that are more commonly understood to be kind of like physical disruptions of a behavior that we talked about in that previous section. That's not about immobilizing a child, but like breaking up a fight, separating kids, where you may have physical contact with them, but not actually initiating a restraint. And then section 17. This is around notifications to children in care. What we did here was broaden notifications to children in care about all child abuse definitions, not just those regarding restraint and seclusion, to make sure that they have a clear understanding of their rights and what is child abuse. And then throughout, you'll see there are conforming amendments to use the terms wrongful restraint and wrongful seclusion to reduce confusion about what we're talking about. And that's really, those two terms are the definitions of when a restraint or seclusion constitutes child abuse. And then section 18 is a statute we were previously unaware of and came to light during the creation of this bill. This exists in the juvenile justice statutes for 19A, and ODHS, youth and ODHS had been included in this statute historically. And what you'll see is that we added language to remove ODHS children entirely from any use of any of these type of restraints during a transport of a child in our care and custody. Then we jump to section 22, still staying within our placement settings, wrongful restraint and wrongful seclusion. Section 22, you'll see is the child abuse definition statute. Oh, give Anna a second. So this is ORS 419B 005, which is our, I refer to them as kind of our like overarching child abuse definitions that apply to everybody in the state. What you'll see is the definitions adds a definition of corporal punishment, wrongful restraint, and wrongful seclusion with references to section 1 of the bill. Again, always pointing back to those universal definitions and the abuse definitions. You'll also see here that we've added in big M, subjecting a child to involuntary servitude or trafficking, as already described in criminal code. And this is really in alignment with federal requirements in the past couple of years that we are becoming in compliance with. Section 23 is amendments to the adult intellectual and developmental disability and mental health abuse definition statutes. And you'll see we removed L and M, which were previously intended to cover restraint and seclusion of young adults in schools. But through practice, this has been determined to be redundant and unnecessary because they're already covered for investigations under H and I of this existing statute. And
I just scrolled up to H and I for a second so that folks could look and see what those said. Michelle, just quick pause.
Can you say that again?
I just scrolled up to section H and I. You just referenced them, but they were off the screen. So I just wanted to let you know I scrolled up so people could look at them. So just a quick
Thank you.
so
Yeah.
folks can read and then we can resume.
Really quick, Michelle, we have a question in the chat. Would it be possible to use person first language, youth who have been adjudicated rather than adjudicated youth?
Yeah, I can definitely ask that question. I know that adjudicated youth is a term that is consistently used throughout the Oregon Youth Authority statutes and other juvenile justice statutes. So what I'd have to ask is if we changed it here, does that have ripple effects in other statutes or not? But happy to ask the question. Section 32 is about requirements on the Department of Human Services when investigating allegations of child abuse under ORS 418 child abuse statutes. What you'll see here is that, again, there are conforming amendments to add OAA foster homes and using the same terms throughout of wrongful restraint and wrongful seclusion when we're talking about what is child abuse. We also make amendments here to ensure that quarterly reporting of restraint and seclusion abuse investigations continue as they do today, and move with the move of these definitions going from 418 to 419B. And then lastly, little d. Yeah, sorry, I'll give you a second to read those. So Anna scrolling down. Keep going, Anna. Here's that quarterly reporting to make sure that we stay consistent with current practice, and then keep going. I think we were at D and E. Sorry, they had to go too far. Little d, little e. Up one more with the bold language. Right there. I just wanted to clarify here, this language is amended to reduce confusion around kind of these reporting points and align with the thresholds that require specific licensing actions. So that as you read the substantiated report, you see the narrative of kind of what was founded for child abuse, and then you would see the section of kind of did any of these things occur, and then there's a licensing response or kind of what actions they took on the license for these things. And when you see check boxes now in any of the middle sections, you should know that those are required to see a condition or revocation or suspension of a license. So just trying to make that easier for people's understanding. And I think lastly, we have section 46. And I know we'll be talking about this one probably in more detail, but this is where the OHSU Institute for Youth would come into play in capturing data around restraint and seclusion trends, also be providing consultation and clinical best practices on this work, a lot of oversight for some of these changes that we're talking about making in this bill. Is there anything else you want to add to that part, Anna, before
I think it's important to identify that this would be in partnership with a youth and family advisory body that would help determine what questions and what data is being looked at by this OHSU Institute, and that one of the specific focuses this institute would have would be to review what the experiences of youth who are having multiple incidents with restraint and seclusion. What is it that the system needs to do better or can change to reduce the rate of incidents for kids who end up experiencing those interventions at a higher level than their peers, right? So some real intentional focus on kids who are experiencing the majority of the interventions, right? And that doesn't just look at wrongful restraint or wrongful seclusion. That's any instance of restraint or seclusion. We see some kids experiencing that a lot. So we want to dig in and really understand what we can do better to support them. I just think that's important to point out.
Thanks, Anna. I'm ready to jump to the section of the policy brief on regulating restraint and seclusion in school settings. And I'm happy to read the challenge that we're trying to address here. So Oregon's current definitions of wrongful restraint and wrongful seclusion in schools are similar, but not the same as those in placement settings. This overlap causes confusion among students, families, and mandatory reporters, as actions deemed child abuse in one context may not be considered abuse in another. This confusion, coupled with the fact that current law places increased liability on school staff directly interacting with children, can lead to a focus on risk mitigation rather than proactive and trauma-informed engagement with students. The proposed changes aim to shift accountability where it belongs, holding school leadership and management accountable for systemic issues like insufficient training or staffing. In addition to being investigated by ODHS for child abuse, violations related to restraint and involuntary seclusion are addressed under Division 22, that's current regulation, standards, and managed through the school's district formal complaint process. If unresolved, the complaints can be appealed to the Oregon Department of Education. However, many parents who've also spoken in front of the System of Care Advisory Council find that this system is problematic as they perceive the school district's involvement as creating a conflict of interest. This potential bias towards protecting the districts from liability rather than impartially resolving the issue can undermine trust in the process and delay meaningful resolutions. And so when we look at the proposed changes to address this, we're looking at, again, that section 1, which is the uniform definitions of child abuse and uniform definitions of what chemical restraint is, what involuntary seclusion is, all getting on the same page in all settings again. I don't think we need to review that whole section again since we've gone over it, but jumping to section 7, or sorry, 2. You go to section 2, you'll see that there is removal of the definitions of restraint, seclusion, serious bodily injury, and instead replaces these with references to section 1 of the bill, again, making sure there's alignment and definitions. I want to also, I think that's the only section in that. I guess I will note, if you had read the previous legislative concept that was a different number, there have been some amendments specifically around this to make sure the language is consistently using serious physical harm. There were some drafting errors that had serious physical injury, which is already a predefined term in statute. Anyway, moving to section 3, this is a school statute. Specifically around restraint and seclusion. And this is what is prohibited. And what you'll see here is that what we did is make amendments that align language between schools and child care caring settings, placement settings. So you'll see little tweaks in here, like including the ground, or if you scroll down, like there's just reorganization of words, inclusion of words or removing of words. Again, just trying to get absolute consistency between placement settings and schools around what is prohibited in the exact same language. That's all for section 3. Section 4. You'll see that some language here has been reorganized for readability, but the key policy changes here are clarifying that restraint is only permissible on a student by personnel of a public education or school district. There are also requirements that remain the same. So if you go, 2 right there, makes it very clear what the criteria are. So the requirements remain the same, with improved clarity on the threshold being serious physical harm and not serious bodily injury, which has caused a lot of people a lot of confusion, and also has not aligned with the U.S. Department of Education and Joint Commission guidance on what the threshold should be to initiate a restraint or seclusion. You'll see again that harm to animals has been included in this section to align consistently across the board. And also, if you scroll down, we've done alignment of language to be the same as in childcare or placement settings around timelines for written authorization for the continuation of a restraint or involuntary seclusion is required. Right, a little bit down and you'll be there. Right there. So it changes from every 15 minutes to every 5 minutes after the first 10 minutes. Section 5. This school statute conforms amendments, again, using the terms involuntary seclusion throughout. Also includes school district personnel. There was a gap identified that substitute teachers are technically not employees of a public education program, but rather of school districts. And so we're making sure that substitute teachers are included in these statutes. And also you shall see, like, again, more conforming language to ensure that when we do refer to serious physical injury for some of those mandated reporting requirements for like death or serious injury. If you keep scrolling down, Anna, making sure that we're making it clear of what statute that term is defined in, and also improving clarity on the types of injuries that have to be reported. I guess that's already there. Great. Section 6 is another school statute. It amends statute to shift responsibility to investigate complaints regarding violations of restraint and seclusion to move from local school/school boards to the Department of Education. This is to mirror kind of the existing process that exists in our placement settings that have a regulatory response to systems. This would not be a response to individuals, like findings on an individual, but would rather be looking at some of these violations and failures and really asking the systems what they're doing to address that or prevent it from happening in the future.
So for instance, this would not be investigating allegations of wrongful restraint or wrongful seclusion. Those would be still investigated by the Child Abuse, the Office of Training and Investigations, right? Otis would be looking into that in the same way that they look at it now. But where we have like a teacher who used a physical intervention that was prohibited by a student's like individualized education plan or 504 plan, but the teacher says they were never provided with that plan. This is where ODE would step in and say, okay, system, your teacher needed this information. They didn't have this information to properly serve the student. No harm was done to the student physically or psychologically, but it was a violation. So what do we need to do better? How can we improve practice so that the system is held accountable rather than the worker being investigated and potentially founded for child abuse? Is that accurate, Michelle?
Yeah, really, it's trying to have a system accountability response to school districts and education programs, very similar to that happens in our facilities and agencies. And then I wanted, if you can scroll down, I also wanted to highlight, this is also the section which would require rooms that are used by public education programs for involuntary seclusion to be equipped with operational video recording equipment. I think y'all are going to be talking about some research and data around that in the future, but just wanted to highlight that's where this falls in the bill. And then section 7 has a bunch of conforming amendments. There really is nothing of great substance here for policy. And then we're going to go
You'll
to
see some changes of terms again for consistency's sake, where we have different statutes that say different phrases, and what we're trying to do is make it clear and consistent across the board what is child abuse and what is not. So we just went in and found places in the school statutes where the terms were inconsistent with what we had done up above. That's what those edits are in section 7.
Yep. Section 20. If you don't read a lot of legislation, this section might be a bit confusing, so I just wanted to explain a little bit. So this is repealing certain sections of existing statute. And this was done so because it was identified that these are really no longer necessary changes because of what we've done to address kind of accountability and liability issues on school personnel when we've shifted to the definitions of wrongful restraint and wrongful seclusion in section 1. And if they were left in, I think they would cause considerable confusion about how they apply because I don't know of any circumstances in which they would apply because they would no longer be things investigated for abuse that would need some type of off-ramp or mitigation. Section 22. Again, we've talked about this section. This is the overarching community child abuse definitions. That is what makes the definitions in sections 1 child abuse, and those again would be consistent in schools as they are in placement settings.
Section I just want to call out here, there were some concerns that the impacts of restraint and seclusion on a child's well-being or psychological functioning was no longer a concern or consideration, and that's existing statute. It exists here
Yes.
under the mental injury definition. It is not coming out. What does change is we changed an and to an or. Some interpretations require that there be harm both to something on this list, psychological, cognitive, emotional, or social well-being, and their functioning, that you have to sort of a test of like, does it actually affect both functioning and well-being? And now we're saying if it impacts functioning or well-being, that would still be meeting the criteria qualification of mental injury. So again, it is a stricter standard than what we are operating under currently.
Yep. Section 23, again, this is the changes to the adult IDD and mental health abuse definition statutes. That does have, again, that no real impact to schools because they're still already can be investigated under H and I of that section, but does make that statute more understandable for folks that are working in those settings and doing those investigations. And then section 46 is again the OHSU Institute for Youth because the data that they will be collecting and providing consultation on also applies to schools, not just our placement settings. And so just highlighting that this ties back to this statute as well. And then section 52, Anna. 52 through 55 are all conforming amendments. You'll see like a section like heading above this in the bill that says conforming amendments. These are ones that have been identified by legislative counsel, like the legal folks who write the bill, to say because you've made these term changes, that has ripple effects into other statutes. These aren't policy changes. They are just amendments to keep language consistent throughout. And then lastly, section 62 is what creates the effective date for the investigations that we have designated to go to the Oregon Department of Education from section 6. And that would require those investigations to be up and running for the 2026 and 2027 school year. That is the end of the school regulating restraint and seclusion section.
Yeah, so I'm just circling back to Rachel because she had some questions about the impact on schools, and then she, at the exact same time, put a comment in the chat. This is going very quickly. Can someone point to me this the section that defines risk of serious physical harm in schools?
Yeah, so there is not a in statute, the term serious physical harm is used in other statutes, but it is not a defined term. And that is a bit intentional, so that there is professional discretion and interpretation of that, rather than having a prescriptive list or description. But we will be providing guidance through rulemaking on how that will be applied consistently by ODHS.
But I think Rachel has like a specific piece of data that she's kind of seeking, and I'm curious. So in those sections that we just reviewed, Michelle, I swear I was paying attention. 20, 22, 23, where is it that we're talking about what where the criteria is that a physical intervention becomes acceptable? I think that's what Rachel's seeking.
So that would be I believe in section 4. Let me verify.
Here we go. It's section 4, subsection 2A. Restraint may be used on a student in a public education program only if the restraint is imposed by personnel of the education program or school district. And Rachel, we kind of glossed over this. There had been previous language that would allow like volunteers and contractors and all of these other people who might be present in the school to engage in restraint or seclusion under certain circumstances. We could not find evidence that those people were consistently trained in the approved physical intervention strategies and models that Oregon uses. And so they would, under this structure, volunteers would not be able to institute a restraint or a seclusion. They would need a staff member who has been properly trained and certified to do those things through TSPC, the Teacher Standards and Practice Commission, or another, if they're a recovery school, they may be certified under some other training licensure structure. But we really wanted to make sure that any adult in the school who could be using a hold, right, a restraint or seclusion, that they would be trained on how to do that safely. And then here's the risk of imminent serious physical harm to the student or others, including animals. So I think that's the language you were looking for clarification on, but feel free to unmute and clarify for me.
The child has to pose a risk of imminent serious physical harm to student or others. A less restrictive intervention would be not effective to reduce the risk. So again, we're talking about what the action was the least restrictive that could be possible at that time. And the least amount of physical force or contact necessary to mitigate the risk was used. That it is not a prohibited restraint as defined in existing school statutes, and that it is not a restraint that would be considered child abuse under Section 1.
Okay, thank you so much. Yeah, it's still a challenge because that like I mentioned, we can't predict the future in terms of what might cause physical harm, serious physical harm and what won't for our staff. But this does provide some clarification, and you mentioned that you'll be providing more guidance in rules in the future.
Yes.
Yeah. And again, I think there's a point here as well of clarifying what Michelle talked a little bit earlier about the difference between a restraint and a physical intervention. Right. So you may not need to put a kid in a hold in order to prevent them from pulling a fire alarm, but you may need to physically redirect them away from the fire alarm. And that has been very unclear in statute. Things have been sort of meshed, and this is pulling those two things apart, those definitions. So
Right. Yeah.
a restraint would be different from a physical intervention in this context.
Great. Thank you.
You're welcome.
So that's the end of the school section on regulating restraint and seclusion. The next big section of the policy bill is around consent authority. And the challenge here is there is confusion regarding the application of existing minor consent statutes to inpatient treatment, with some mistakenly believing that a youth has the ability to consent to or refuse behavioral health care at levels beyond outpatient services. This misunderstanding can create a false impression that a youth has an implied right to refuse higher levels of care, potentially delaying or hindering appropriate intervention in a crisis situation. So the sections of the bill here are sections 42 through 45. And you'll see section 42 is a new statute. So all the bold language means it's all new language, and it would be a new ORS. And this is really about parental admission of a minor for inpatient treatment. It defines who a child is, and then it explains in section 2 that a parent or guardian may consent to the inpatient behavioral health treatment of a child if, and then gives the following criteria about that admission decision being made by a neutral licensed healthcare professional whose scope of practice includes diagnosis and treatment of behavioral health disorders, including substance use disorders. The neutral licensed healthcare professional determines inpatient behavioral health treatment is medically necessary and in the best interest of the child, and which means all three must exist. The child is regularly evaluated to determine if inpatient treatment remains necessary. And then 3 there requires the Oregon Health Authority in consultation with the Department of Human Services to adopt rules to implement the provisions of this section. Section 43 is clarifying the prohibition on refusal to treat. So again, it has the definition of child, and then it has in section 2 clarification, and this is actually very similar to what Washington State had to do to address this concern, which is a healthcare professional may not, based solely on a child's objection, refuse to provide the child with inpatient or outpatient diagnosis or treatment of a behavioral health disorder, including substance use disorder, that is consented to on the child's behalf by the child's parent or guardian. Section 4 is some clarifying language around,
Sorry, section 44.
Sorry, section 40, yeah, sorry, thank you, is clarification and some language change here around a minor 14 years of age or older consenting without the knowledge or consent of a minor's parent or guardian. So this makes it very clear they are still able to consent without the knowledge or consent of their parent or guardian for outpatient diagnosis and treatment. Just clarifying that language to make it a little bit cleaner. It does not change what is existing practice. Continue. And then lastly here, it amends the language so that a person providing treatment to a minor who consented to the treatment as provided in this section shall involve the minor's parent or legal guardian in the minor's treatment as soon as possible after commencing treatment unless, and then it has again 3, looks like more than that, more criteria for what would have to exist. And these are all ors, which means that they stand alone. They don't have to be cumulative. So the minor's parent or guardian declines to be involved in the minor's treatment. B, there is clear clinical indications that parental involvement would be contrary to the best interests or health of a minor as documented in the treatment record. The provider is prohibited by federal law from disclosing information about the minor's diagnosis or treatment to the minor's parent or guardian, and then goes into other conditions that currently exist around sexual abuse and emancipated minors. And then section 45, and scroll down. It's just a few clarifying pieces of language here. I don't think that there's anything substantial in this section. Anna, did I lose you?
Michelle, I can't hear you. Your audio is cutting out.
Can you hear me now?
Yes.
Okay. Can you go to scroll down in section 45?
Yes.
Michelle, we have a couple questions in the chat. Do you mind?
Yeah.
Okay. There is a question here. I thought we had discussed removing the ABA language in prior meetings.
Let's see if you can scroll back up, Anna. I think that's existing language.
It was on page 24, I think, when I looked last night, but I'll try to find it again.
I think it's in section 44, Anna, because I think that's where they're talking about outpatient.
Yeah, it's where the 14-year-old can give consent for themselves. And I'm concerned that in residential settings, it's opening the door for more ABA to happen in those settings.
So I think that you're referring to little b here, and that is all existing language that we have not changed.
Correct. We did remove it from the whereas clauses in that discussion, but we did not remove it from this section here that a youth could consent to the care. That is a conversation that so the sort of the why, and today is it just a what's in it, what's not in it kind of conversation. And Amy, I know that you were a part of the legislative conversations, and so we'll be talking about any amendment suggestions and ideas on March 4th at our full council meeting for public comment, as well as our legislative committee meeting on March 5th from 8:30 to 9:30 in the morning. Or you can always email it to me, and I know you weren't here at the beginning when we made that announcement.
Okay, so we've gotten through the minor consent or consent authority sections of the policy brief. I do just want to say this language here, I am definitely not the subject matter expert on, but we had great collaboration between the Oregon Health Authority, ODHS, and Oregon Health Authority attorneys working on this with legislative counsel, who was also very familiar with some of these concerns, as a lot of this minor consent and parental authority has been confusing in numerous states. And so that work has been, I think, pretty well vetted through the Oregon Health Authority and attorneys to try and get this very narrowly right for what we're trying to address around inpatient behavioral health care. Going to the next section of the policy brief, which is on secure transportation, starts us on section 8 of the bill. And secure transportation providers are child caring agencies and required to be licensed. What this, the amendments, thank you for reminding me about the challenge. I'll start there. So secure transportation services are occasionally needed by parents or child welfare to get a child safely to a treatment program. Senate Bill 710 in 2021 was intended to regulate secure transportation providers to better protect children in Oregon, but inadvertently caused a complete shutdown of secure non-emergency medical transportation services by requiring them to be licensed as a child caring agency. They currently are already regulated by the Oregon Health Authority. This has left children stranded in hospitals and child caring agencies, unable to be legally transported for medically necessary treatment. Then in 2022, while Senate Bill 1547 made some amendments, it did not fully remove the complex overlap between medical transport and child caring agency regulations, resulting in fewer medical and non-medical transport providers willing to serve children. Additionally, the current statute, ORS 419A, regulating the use of mechanical restraints during the transportation of children in child welfare or juvenile justice custody, is outdated and does not align with the current standards for treating children in the custody of ODHS. And we've talked about those as well. So looking at section 8, this removes really confusing definitions of secure escort and secure non-emergency medical transportation provider, and makes one uniform definition under secure transportation services, and additionally amends any reference to medical transport to make it a very clear policy that medical transport providers will be regulated only by OHA, and non-medical transport providers will continue to have the same child caring agency regulation requirements, but kind of disentangling where there has been confusing overlap between the two. Section 18 also impacts secure transportation providers. And then we've talked about this section where we're removing ODHS youth from this entire statute. So now it only applies to juvenile justice youth so that it makes it abundantly clear there is no authorization or ability for a transport provider to use any type of restraints that are included in this section of statute on a ODHS child. And then lastly, section 59 is conforming amendments around secure transport providers, but does not have a substantive change here. That is all for secure transportation. Going into treatment access for children in foster care, the challenge, children in foster care have more limited options for treatment than children on the Oregon Health Plan, children in the juvenile justice system, or children covered by private insurance. Current law prohibits children in foster care or in child welfare custody from receiving inpatient treatment from any facility that is not licensed as an Oregon child caring agency. This means they cannot receive treatment, even when medically necessary, from a provider outside of Oregon. This is especially challenging for tribal children seeking culturally appropriate care. They may be out of state, and children who live outside the I-5 corridor seeking more convenient options in neighboring states. In addition, there are time limits that apply to children in foster care for certain in-state placements that do not apply to other youth in Oregon. These differences create inequitable outcomes and lead to foster children being placed in temporary lodging. The key sections to look at around treatment access for children in foster care starts in section 32. ODHS investigation requirements for investigations of 419 child abuse definitions. What you'll see here, did I get that right? 32. Oh, I think this refers to out-of-state investigations, and just make sure that there's conforming language, that we are doing the same actions in our abuse investigations, whether they're in an in-state CCA or if they are in an out-of-state placement. Some of that quarterly reporting is what includes out-of-state child caring agencies. Section 36 is really where we get into the substance of the exceptions to be made for the regulations that will continue to require licensing and specific contracting of out-of-state providers. So you'll see that the language vastly stays the same with these same requirements, but subsection 7 has specific limitations. If you could scroll down to section 7, Anna. So I will say, before diving into the actual types of exceptions, I think it might be helpful to go over kind of what parameters have to be addressed for an approval for one of these exceptions first. It does require the Department of Human Services to verify that the program is in good standing in the state in which they're licensed. It requires notification to the System of Care Advisory Council. When it's an out-of-state placement, that's within 7 days of the placement, and approval by the child welfare director for all incidents. And then when it has been deemed medically necessary and appropriate treatment per Medicaid, it would also require the Medicaid director to approve this placement exception in addition to the child welfare director. It also requires collaborative rulemaking on the approval process by ODHS and OHA, and requires OHA to contract with CCOs to address standards of care for all OHP, Oregon Health Plan, Medicaid receiving children when they're receiving care out of state. What we're really trying to do, again, is to have equal access for children in foster care for these same placements and services and treatment that any other child on the Oregon Health Plan would have access to. And so when we go into the specifics around what these exceptions are, Anna, if you could scroll up. So I'll just read through this section because I think it's important for you all to hear the language. So the department may place a child in an out-of-state placement without requiring the placement to be licensed or under contract as described in subsection 1 of this section, or a qualified residential treatment program as described in ORS 418.323 if the child requires specialized services and treatment and no suitable child care and agency placements are available in this state, and the services and treatment are authorized by the responsible Medicaid entity for coverage by Medicaid. B, the out-of-state placement is requested by the child's tribe or as a youth residential treatment center funded by Indian Health Service. C, the placement is an out-of-state child caring agency. The child resides in a placement subject to the Interstate Compact on Placement of Children that is located in the same state. Anna. As or a neighboring state to the child caring agency. And the child caring agency provides the types of inpatient treatment, medical care, or services that a child requires consistent with rules adopted by the Oregon Health Authority for the admission of the authority's program providing benefits for children and young adults with special needs. D, the out-of-state placement is approved by an adoption agency or a foster care agency or provider of similar services in the state of placement, and the adoption agency or foster care agency provides licensing services in compliance with paragraph B of Article V of the Interstate Compact, ICPC, or E, the nearest medically necessary and appropriate service for treatment to the child's community as a neighboring state. Accessing services or treatment out of state maintains the child's connection to the child's community, and services or treatment are consistent with rules. Oh. Sorry, got lost there. Rules adopted by the Oregon Health Authority for the administration, program providing benefits for children and young adults with special needs. It does not, out-of-state placement of a child under this section is not subject to subsection 4, 5, and 6 of this section or court approval under 419B.351. And then we've talked about the criteria already that are in CD and further below. I think it might be helpful to kind of talk about each one of these in more common, I don't know, like common situation language, if that's okay, Anna. We can go back up to A. So A is really about those circumstances in which a child is currently in Oregon and has an identified medical need that does not exist in Oregon. A common example of this is specific eating disorder treatment that does not exist in the state of Oregon. And until we have options in Oregon, if that's deemed necessary, we are at times going to need to allow our children in the custody of child welfare to get that treatment in a regional appropriate setting that other children on the Oregon Health Plan receive. B is really about tribal sovereignty and recognizing that tribes who have a request for their child to go to a specific congregate care placement or out-of-state placement, that we honor and recognize that, and do not require the same licensing or contracting requirements or force the tribe to have to take custody of that child in order to get them that type of care. C is around when a child is placed with relatives or a pre-adoptive family out of state, and they have a mental health crisis or behavioral health crisis and they go to the hospital and it's recommended maybe they step down into subacute before they look at discharging into lower levels of care or discharging home. And right now, those children are having to return to Oregon because we're not able to do the licensing and certification requirements in these other states. We've had no willing out-of-state providers willing to go through licensing and regulation requirements by Oregon and have dual licensing. And then so that allows that child to stay in their state where their family or pre-adoptive family is and be able to do the step-down behavioral health services in that state. And lastly, D is about some states don't have child welfare services that do certification of foster homes for relatives or pre-adoptive placements. They contract that, the state or county contracts that out to private agencies. And what we're trying to say here is that if that is the practice of the state to subcontract with these providers, that we don't have to license those providers as a child caring agency in order for that child to be placed in a certified home in that state. So we're increasing access to permanency faster and not having any undue delays because of how that state certifies specific homes. And then E is really about our youth that are in bordering cities or areas. So I immediately think about Ontario or Eastern Oregon or Milton Freewater or Pendleton, where it is common for those communities for their more high acute access to care to be either in the state of Washington, like in Walla Walla, or in Boise, Idaho. And so it's creating opportunities again, as any other child on the Oregon Health Plan would have, that children in child welfare custody would be able to access behavioral health care in those states. That isn't always necessarily a placement, but it could also be serving day treatment type care that would also require a CCA license as it stands today. So those are really the key exceptions. Again, they would have requirements for approval by the Director of Child Welfare and the Director of Medicaid in certain circumstances, have reporting to the System of Care Advisory Council to start tracking some of the data around how frequent this is being used, the circumstances in which it's being used, and really try and identify if there's gaps in our current system in Oregon around services that we need to look at building capacity around based on those trends. Next is section 37.
Before we move on, Michelle.
Thank you.
Judge Gates looks like she has a question.
Okay.
Can you hear me?
Yes.
I had a question about subsection D. And
Okay.
that when it says, when the department places a child in an out-of-state placement under the subsection, the department will provide written notice of the placement to the office of the governor and the System of Care Advisory Council within 7 days following the date of placement. So with the latter one, I'm wondering, when this council gets that information, what responsibility does that next require of us?
And I'll pivot that to you.
Judge Gates, we're going to have to convene a group of people to review those reports. Our data specialist will be a part of that conversation as well to support us in tracking trends. We will be including it in, there's a whole section of mandatory reporting work that we'll have to do at the very bottom of the bill regarding implementation and impacts of the implementation of the bill on different populations. So what we'll be doing is like watching for, we suddenly seeing a bunch of kids going out of state for some reason. That's a problem. We need to raise the red flag. Are we seeing that there's a pattern of kids going out of state with for particular reasons? And like, that would be our job to elevate it for the legislature or the Oregon Health Authority or whoever would be the right body to support development of the service in the state. Right. So we would be interpreting those reports and then because some of the reports, if I'm being honest, that you can read online right now are very identifying with regard to kids who are needing care in complex ways. And so we would be a place to like review that information and put it out there in a less identifying way for action by the governor's office, the regulatory bodies, the public, right? So we would be we could at any point make a public action in regard to those reports, and we are periodically required to report to the legislature on any patterns or trends that we see in those reports that are sent to us. Does that
Thank you.
answer your question?
Yes, it does. Thank you.
So section 37 gets into our in-state congregate care regulations for children in the custody of child welfare. We added some clarification here on what is not a congregate care setting under these statutes. Some examples are around Job Corps programs or ODDS licensed residential facilities. We've had some youth that have been interested in the Job Corps program, and right now it appears to be not allowable because it'd be considered a congregate care setting that is not licensed as a child caring agency. So we're trying to open up that opportunity for some of our youth if they are so interested. We also have exceptions down here. Great, thanks, Anna. To allow for, in limited circumstances, a child to be placed in an adult setting when deemed necessary by a responsible Medicaid entity. An example of this could be a 17-year-old who has a substance use disorder, and the most medically appropriate and necessary and appropriate care could be an adult setting that may meet their needs very uniquely, like if they have an infant of their own in their care and they're able to be reunited with their child or continue parenting their child and receive substance use disorder treatment. We've also had incidents where we have not had providers for children with specific language needs, and an adult setting would provide that for an older youth. This would not necessarily be a broad practice, and this also has the requirements of the child welfare director and the Medicaid director having prior approval before any of those decisions are made. It also allows for an exception in non-qualified residential treatment program settings when it meets criteria. And thanks, Anna. That really, right now, there's very strict limitations for youth in the custody of child welfare to only be able to stay in one of these placements for 60 consecutive days or 90 accumulative days in a 12-month period. And this allows for limited exceptions when it is requested by a child to stay longer, that they would have that ability to self-advocate, and that those placement times would not be applicable to them, or that the agency would not be in violation of law if a child continued to stay in one of those placements. We've had some children that have found that this is the most safe, stable placement they have found as they're entering adulthood, and would like to have that continuity of a placement as they're entering kind of the next stage of their life of independence. And then for the agency, we often have times, to give you a scope of kind of how many children this is, on average, this is 12 children a day that are in one of these settings. This is not a huge number of kids that are experiencing one of these types of settings, but there are times when we've identified a permanent placement or next placement, but it is just beyond the 60 consecutive days, and we're having to create a placement disruption just for one night in order to continue in that setting until the permanent placement the child can be moved to the permanent placement. And we're really just trying to have any unnecessary placement disruptions, if at all possible, for kids in our care. So it adds the agency to be able to have an extension of 30 consecutive days or 30 accumulative days in a 12-month period. And that would be criteria defined in our rules. And this section, as I said, also has the approval structure as out-of-state placements with the Child Welfare Director and Medicaid Director having prior approval, and also has reporting requirements to the System of Care Advisory Council. But for these, it isn't within 7 days. It is on a quarterly basis to be able to provide those reports. Section 38 is only conforming amendments, nothing of significant policy substance. And then section 39 shifts away the requirement for ODHS to post monthly on a website a lot of pretty specific details around a child who has been placed out of state, and shifts that instead to a quarterly report to the System of Care Advisory Council with many of these same details. And again, this would be in addition to the within 7 days notification of the placement, but would just be on a quarterly basis, kind of that fuller report of all this detailed information.
I just scrolled down so that they can see the rest of the requirements of what would be included in that quarterly report, Michelle.
Yeah, and then lastly, section 46, the OHSU Institute for Youth section of this bill also has specific oversight over these exceptions for out-of-state and in-state placement exceptions, so that they can be providing, again, that clinical oversight of some of these decisions that have been made. And that ends our sections on the treatment access for children in foster care. So the last elements of the policy brief are under the technical and clarification sections of the policy bill. I just want to do a bit of a time check if we should just run through this for the rest of the half an hour, or if the System of Care Advisory Council has any other thoughts or suggestions. Just want to pause. Okay. So this bill does address several other challenges brought to the System of Care Advisory Council by families and youth with lived experience, state agencies, youth advocates, and organizations that serve children. I already highlighted this, but in section 22, we do add human trafficking as a child abuse definition to align with federal requirements and guidance. In section 19, there is an existing statute that was amended in 2023 that had a shall instead of a may around a requirement for mandatory reporters to have an electronic reporting system with the child abuse hotline. There's misinterpretation about what that shall was. The child abuse hotline has done a significant amount of research since that bill's been passed, and has kind of hit some key kind of decision points about how the state wants to move forward with something like this, or if it is even based in in evidence of what would be the best for child safety. Some other states have done this and have had mixed results. I think Oregon needs to take a really close look at that research and some of the implications that other states have felt from this, and some have moved back from electronic reporting model. And so making this a may will clear up and give us a little bit more time to be in compliance if we are going to move forward with an electronic reporting system. But at this point, there is a lot of discussion and policy discussion that needs to happen in the legislature and with the agencies and community partners before just moving forward with something like that. Section 41 establishes in statute what has been longstanding practice to exempt young people aged 18 or over who are in the custody of child welfare and are placed in a foster home. And when they continue to be in a foster home beyond the age of 18, there is interpretation today that they may or are required to have a criminal history check to remain in that home, which includes an FBI fingerprint check. And really, the longstanding practices, we have not done this on children. We know as they've aged in our system, and we know a lot of, of the details of their criminal history, their child welfare history, and understand what may need to be done to address any or mitigate any safety concerns with other children. We have heard from youth that it would be harmful and concerning to them if on their 18th birthday or shortly after, if they had to do an FBI fingerprint check to remain in the foster home that they have lived in. The next one is reducing housing barriers for older youth, Section 40. There has been a longstanding requirement in statute for children in independent living facilities to contribute to housing expenses and support costs. And we have stopped that practice of requiring youth to pay this as it's become a barrier for them seeking this type of housing, and it's been unnecessary. And so the Oregon Department of Human Services has already started fully funding the placement rate in an ILP setting through treatment services. And really, we're just taking this out as an unnecessary barrier for accessing essential services for these youth. Section 15, we talked about this one as well already, providing an opportunity to review video of alleged restraint and seclusion violations and require consent of the involved young person if age 18 or older before the video is shared with eligible parties. Section 10, I do want to highlight for folks as it may look really concerning on its face. What you'll see is that Legislative Council recommended that we move the definitions of child abuse in 418 to its own section of statute for readability and improved organization. So it may look like we've deleted all these definitions of child abuse in 418, but they've actually just been moved into their own special statute. And so what you'll see there at the very top, and I want to show, it also adds a clarifier of who is investigated under these definitions to make it very clear, as there's been some ongoing confusion about what the legislative intent was for the application of these definitions. And really what this comes down to is those who are responsible for providing care to a child in care, which is a child receiving services or residing in a child caring agency, a DD group home or foster home, or a child welfare certified foster home, or a OYA foster home. If somebody owes a duty to care because they are in one of those settings or receiving services from one of those settings, then they would be investigated by the Department of Human Services under these abuse definitions. I know this has caused a lot of confusion between how the application of the broad community child abuse definitions apply versus these definitions, and hopefully this provides some clarity of how that is separated. This will also improve a lot of clarity around our data reporting and understanding when a child has suffered abuse while in care. Really, kind of what does that look like between somebody who owes a duty to care for that child versus somebody in the community, and really separating those out by the abuse definitions that are used against those individuals. Sections 11 through 14, 31 and 22. Again, we've talked about this, but it expands the definition of a child in care to include Oregon Youth Authority foster homes. This is pretty exciting because that means that foster homes for children, regardless of who is the certifier, will be treated equally and reported on equally in terms of quarterly reporting to the legislature, as well as abuse findings and required actions by the agency when certain concerns or deficiencies are found by the agency in one of those settings. So it really makes equal protection across foster care for all kids in Oregon. Section 27 is a pretty significant piece of legislation, but a pretty pragmatic one as well. It amends the options of the Oregon, the Child Caring Agency Licensing Authority, who is located at Otis, from having all of the options available to them around licensing actions that are equal to other settings, like in the DD system, the APD system. I think those are the two I'm thinking of. And so right now there's a statute that specifically requires suspension or revocation of a child caring agency's license in certain circumstances. And by adding the ability to place conditions upon a license in those circumstances aligns with all of the other licensing requirements of other agencies. And then Section 27 adds a narrow corporation exception status. So currently all child caring agencies are required to be corporations unless the type of services provided, regardless of the type of services provided to the child. So this bill introduces a narrow exception to this requirement, allowing similar service organizations, such as direct support professional organizations, which are authorized by the Oregon statute to operate in limited liability companies or LLCs, to also be licensed as child caring agencies without having to change their status. Under this exception, companies must establish advisory board and comply with additional standards to ensure the child's safety. And those requirements will be set in rule by the Oregon Department of Human Services. We also hope that this will encourage other programs from out of state who are LLCs who have been interested in serving Oregon children for also being considered to be licensed as a child caring agency in Oregon. Section 32 aligns quarterly reporting to make sure that the reports I think I talked about this, that when there is a specific condition that requires one of those mandatory actions of condition, suspension, or revocation of a license, that we are consistently capturing that in the quarterly reports to the legislature. So it's a very clear, linear, if there's a substantiation, if there are these things, then you should start to see one of these mandatory actions in the licensing section of that report. That was a lot, y'all. So I'm gonna take a second. I know there are still sections of the bill that have conforming amendments or small edits that I probably did not cover, but those are the biggest policy sections of this omnibus bill. And again, happy to answer any questions or whatever the System of Care Advisory Council would like to do at this point.
I think additional questions for clarification would be great. I think the sort of why or what is the logic behind, like, those are conversations to have in the full council or in the legislative committee meeting. Any questions for clarification? I don't understand that. I don't know what that word means. That's what this meeting is about. So please speak up, raise your hand, chat Joylene, unmute yourself, whatever it is. There is, like, seriously no dumb question. Like, it takes years to learn how to read statute, and even still folks who are used to it get confused by it. So if you don't understand something, I guarantee you someone else in this room also doesn't understand it. Okay, well, I think you did apparently a perfect job, Michelle, because people don't have questions. I wonder about moving to the frequently asked questions document and just talking through that, since we have about 15 more minutes left, and then we can discuss whether we want to do the same thing on Thursday night, kind of the same run through, or how we might handle it differently? Does that sound okay, Michelle?
Which document did you want to run through? I'm
A
sorry.
frequently asked questions document?
Yeah, absolutely.
Okay, let me stop sharing for a quick moment and pull that up. So the first frequently asked
question is, does this legislation make it easier to restrain or seclude kids? The answer to that is no. The legislation does not change the requirements that restraint and seclusion are used as the last resort when no less restrictive intervention can prevent imminent risk of serious physical harm. It maintains Oregon's existing high standards for third-party abuse and makes them consistent across child caring agencies, residential care for children with disabilities, and school settings, so there's no ambiguity in what is considered abuse and against the law. Question number 2, does this legislation change in any way what is considered abuse? No, abuse is abuse. The legislation puts everyone on the same page so that providers in any setting know there's no technicality or confusing application of what is simply understood as abuse. Is it true that the bill will result in Oregon having some of the lowest protections related to restraint and seclusion in the country? No, Oregon is currently, and with the proposed amendments, will continue to be among the top 10 states in the country for strong regulations concerning restraint and seclusion of children. Will some restraints be permissible that are now prohibited? No. The regulations existing in statute regarding prohibited restraints and seclusion, including procedures, record keeping notifications, and training standards, all are remaining unchanged as they're essential for protecting child safety. What is being changed is how we investigate restraints, not changing what is considered prohibited. The next question, won't sending kids out of state remove the ability for the state to provide oversight and ensure child safety? No, this bill strengthens oversight measures by requiring the child welfare director's review and approval for any exception, as opposed to a case manager, which was common practice prior to the passage of this legislation. I think it was in 2019 or 2020. Additionally, the System of Care Advisory Council will receive and monitor reports on every out-of-state placement, and an OHSU-based institute will oversee clinical best practice and evaluate trends for treatment gaps. There are currently not enough providers in Oregon to serve all level of needs, and the state has. While we grow the provider workforce in Oregon, this bill carefully and narrowly amends statute to increase access for children and young adults in the custody of child welfare to have equal access to placements and treatment as their peers on the Oregon Health Plan or private insurance. And I'll just say we did have one child that went out of state this summer and in violation of Oregon statute, and that child was visited on a weekly basis. And so I think we've shown a model that's been able to look at how we can provide the oversight in those settings, and by kind of a multidisciplinary team, in that case, both a licensor, the child's caseworker, and a child psychiatrist contracted by the state all visited that youth to ensure that they were receiving the best level of care and maintain connection to folks in Oregon. Will this legislation reduce safety standards that are in place in Oregon? No, safe and appropriate contact with a child remains the same in this legislation. Will this add children to the civil commitment process? No, this law aligns Oregon statute with federal law to allow parents to provide mental health treatment for kids under the age of 18, specifically not getting into what will need to be a very robust conversation around if civil commitment can and should apply to youth or minors in this state. Why is the state focused on changing regulations instead of working to build capacity and train providers? We must do both. Improving youth behavioral health and access to treatment is a multifaceted approach. The governor's recommended budget includes new and critical financial investments to grow capacity and build our workforce. Something that you will often hear from the agency is we have requests for proposals or for contracts to serve some of our youth with essentially a blank check, and providers have thus far been unwilling to step into that arena, citing the regulatory environment and high liability of current regulations that is prohibiting them from stepping into that space, regardless of the financial investments that exist. Who is a regulated child caring agency? So we have on there a link to the website if you'd like to look at all of them. I think there's close to 70 some that are currently licensed in Oregon. But they include academic boarding schools, adoption agencies, day treatment programs, foster care agencies, homeless, runaway, and transitional living services, outdoor youth programs, residential care programs, secure transportation services, and therapeutic boarding schools. What I will add to that section is that Oregon at this point has lost all of its therapeutic boarding schools as well as outdoor youth programs and currently has none licensed in this state. Who is impacted by regulating the use of restraint and seclusion in placement settings? So that's really our child caring agencies are impacted, residential facilities for children with intellectual and developmental disabilities, child welfare certified foster homes, intellectual and developmental disability certified foster homes, Proctor foster homes, those are the ones licensed by child caring agencies, and the Oregon Youth Authority certified foster homes. Who's impacted by regulating the use of restraint and seclusion in schools? Public education programs are, school districts are. You could probably list youth and families and a lot of other folks there. Who's impacted by consent authority section of this bill? All children in Oregon, all legal guardians in Oregon, hospitals, inpatient providers, to name a few. Who is impacted by secure transportation section of this bill? Again, all children in Oregon, all medical transportation providers certified by OHA, and all non-medical transportation providers certified by ODHS as a child caring agency. Who is impacted by treatment access for children in foster care, children and young adults who are in the custody of child welfare, non-qualified residential treatment program providers such as homeless, runaway, and transitional living shelters who'd be able to maintain those children in their home without, or in their settings without a placement disruption or at the request of the child. Would love to hear or get feedback if there are other questions you think should be added to this frequently asked questions document as well, but that is what we have so far.
Well, I did not know when we set this up that 2 hours would be like the exact amount of time it would take Michelle to walk all the way through the bill. Well done. I appreciate everyone's questions. Some of the comments in the chat about, kind of why or expressing opinions or suggestions. We have noted them. This is, as we've mentioned, not the place for that conversation. So we'll carry those pieces into future conversations, both at the full council meeting, which will be March 4th from 12:30 to 4:30 p.m. as well as March 5th, the Legislative Committee meeting, which is 9:30 or 8:30 to 9:30 a.m. Those meetings are available publicly on from links on our webpage, and you are welcome to join. There's a public comment period during the full council meeting that is included on the agenda. I believe it's at 2:40 p.m. For the March 4th meeting. This will be posted on the internet on our YouTube page. However, it may take us a couple of days. I think Joylene kind of indicated it might be ready by tomorrow. Not the case, so don't want to have misinterpreted expectations. That we're going to do timestamps to say, like, for this section, it starts at this time. For this section, it starts at this time, so that folks can navigate and not have to watch the whole thing if they have one particular topic of interest. So that will take us a couple of days. Informational and public hearings have yet to be scheduled. We have requested mid-March. Those will be available as well on our website as well as on OLIS as soon as those are scheduled and confirmed. And I see Emily Cooper has a question.
So my question is more on process. Do you know, like, what's the plan in terms of the informational hearing that we had our consensus model, but we weren't unanimous in support of this, and that we had the approve with reservations? What's going to be the process for that?
I don't completely understand your question, Emily. Can you try and say it in a different way?
Yeah, so I know like informational hearings are usually for just the supporters of the bill. It's just for information. And so will there be opportunities for those who didn't block it, but agreed with reservations to express their reservations at the informational hearing?
I don't know. That is the chair of the House Human Services Committee is the person who has the authority to set the agenda for that informational hearing and just determine who is invited and how long they are scheduled to speak for. So that is not something that is within the System of Care Advisory Council's authority or control.
Maybe another way, will it be conveyed that it wasn't unanimous?
That there were folks who voted with reservations or stood aside.
Yeah, or had concerns.
I don't know if that will be included in the informational hearing. That is absolutely something that any member of the public could mention in the public hearing, which will also take place in that same committee.
Yeah. No, I mean, like, as a member of the SOCAC, I'm concerned about this. And I don't know if that concern, if it's going to be presented as this was a SOCAC unanimous bill, or if it'll be presented differently.
Unknown, Emily. That is a conversation I think we could absolutely take offline.
Okay.
And that bill number, House Bill 3706, is not the correct bill number, but thanks for trying, Leah. There was some fatal flaws in House Bill 3706 that did not conform to the intent that Michelle was discussing earlier with one clear, consistent definition of child abuse across all settings. There were some places where they missed some of that, and so we do not have a bill number yet. We got those edits by submitting yet another bill draft and having it, so it is a new LC number. It is a new bill number. The LC is currently, the new LC is LC 4714, and there is no assigned bill number yet. So I'll put LC 4714. That is the legislative concept number that we were working from today in this conversation, and that will be introduced as the introduced measure into the legislature. That is does not exist on OLIS yet. You can't find it, but once a bill is posted, if you search by LC number in OLIS, you can search by LC 4714 and you would find the bill number associated with this legislative concept, whatever that ends up being. I know it's been really confusing. That's why we haven't sent out a bunch of publicly facing materials yet, because we want to get the actual bill number. And then all of the documents that we reviewed with you today will be posted on our website and shared broadly publicly with the correct bill number included. All right. Well, I appreciate everyone's time. Appreciate your engagement in this conversation, and we will notify if we're going to do a duplicate of this on Thursday night or what else might take place. So keep your eyes on your emails and your calendars. Appreciate you. Have a good rest of your evening.